This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
All right, guys, welcome back. Second episode into season 3. I believe it's episode 33 now. I got Nathan and Kaushik here. I'll let them say what's up.
Hey everyone, I'm Nathan Kulapur, fourth year medical student here at Northwestern, interested in internal medicine, and we're excited for the show today.
What's up, world? This is Kaushik, also fourth year Feinberg student with Nathan. Glad to be back.
And so I have some dear friends and fellow classmates, Tina and Trish, joining us on the podcast, so I will let them go ahead and introduce themselves.
Hey, I'm Tina Shihata. I'm a fourth year med student at Feinberg. I'm going into diagnostic radiology. I'm originally from a suburb of Chicago. And a fun fact about me is in 8th grade, I was the school mascot.
Oh, what was your mascot?
It was a Jayhawk. The
Oh.
Jayhawks. Maybe that should be off the record. That I shouldn't be revealing my identity.
And I'm Trish. I'm also a fourth year medical student at Feinberg. I'm applying into medicine, dermatology, and integrated residencies as well as dermatology. I'm originally from Bridgewater, New Jersey. And a fun fact about me is that I have a social media account dedicated to making toast.
Oh, toast. What's the...
Follow you. Do I? I think
You must.
I hope you posted in a
How
while.
often are you making toast?
I mean, I make toast pretty much every day.
What's the best kind of toast you've made?
That was my question here.
I think the most recent favorite for me is this like olive focaccia that I bought, and then I put some baba ganoush, which is like a roasted eggplant spread on it, with some za'atar, which is Middle Eastern spice.
Oh, heavy duty toast.
It's enough that I made an account for it. So
Great.
All right, so without further ado, let's go ahead and get into the first aliquot of the case, see what's going on. So, we have a 40-year-old male with past medical history of alcohol-associated cirrhosis and chronic kidney disease, status post-combined kidney and liver transplant 6 months ago, and type 2 diabetes, who presents with fatigue and anemia. So, what are your initial thoughts?
I guess my initial thought is like, all right, this patient's pretty young. He's already been through a lot. He has a lot of like chronic conditions. And so that actually makes the like, differential pretty wide. I think, being like having a transplant, you're like immunocompromised, like any infections that you're going to have, any like complications from the transplant, also like rejection or chronic kidney disease, all the host of things that go along with having long-term that. And then diabetes is like super common, but like there's a lot of different manifestations of that as well.
yeah, I totally agree. I think there's multiple levels of immunocompromise for this patient, and I also think about even if he has had 2 different solid organ transplants, he might not be at full functioning of those 2 transplanted organs, and they're both very vital for several different metabolic processes which can drive fatigue and anemia. So definitely I agree with the broader differential. And then it's also the type 2 diabetes, which is also contributing to his immunocompromise.
Yeah, love the other keeping a broad differential right now. And these like presenting symptoms, fatigue and anemia, like those are pretty broad, chief complaints. And also love that you're tuned into the fact that, he's a transplant patient on immunosuppression, so having all those considerations. Okay. Is there other information that you would like sort of be keen on getting at this point? Help further narrow your differential?
I guess a little bit more about the time course of the fatigue and anemia. I'm assuming, like we've alluded to, that this patient has been through a lot of stress through surgery. So I'm curious if the fatigue is something that's been there since peri-operative or if it's a new thing. And I'm also curious if either of the transplants were complicated by anything in the acute setting, either something like GVHD or rejection or any infections.
Yeah, I think just like thinking, did he feel better at some point from the transplant or like since the transplant? And also, I think just like when you like first walk into the room and kind of like look at the patient, you can kind of tell like, is this like how sick is this person?
Right.
And like
Sick versus
this
not
person I'm like picturing as someone like pretty sick, but I think someone could present with fatigue and anemia and like look okay. So I'm kind of thinking about that.
Great. Yeah, great consideration. So let's get some more information, shall we? So he has been having generalized fatigue for the past 2 to 3 weeks. He's also noting new and progressive shortness of breath, also complaining of a headache for the past week. So we get some labs done and urgent transplant-related imaging before being admitted to you. So his white count is 2, hemoglobin 7.2, platelets 259, sodium 132, potassium 5.8, creatinine 2.33 with a baseline of 1.6. Liver panel is within normal limits. His COVID test comes back positive, and then some imaging related to his transplant grafts. The renal transplant ultrasound and liver transplant ultrasound are both normal, with patent vessels, normal resistant indices. So, given this, what are your thoughts? How's your differential changing?
So a couple of thoughts. So this patient is pretty profoundly anemic. The hemoglobin's at 7.2. We don't have a baseline, but just off the bat, that can be responsible for fatigue. Makes me worry that he might be bleeding from somewhere, or you could think about just kidney-related failure and inadequate EPO to produce red blood cells. He doesn't have a leukocytosis, so maybe I'm less worried about an urgent infection, but he's immunocompromised, so maybe less likely to mount a neutrophilic response to infection. His creatinine is pretty elevated from his baseline. I'm assuming this is post-transplant. Baseline was the 1.6, so that's concerning that there's some kind of injury to the kidney. And then the COVID positivity, which I don't know, Tina, you were going to talk about that though.
His potassium is pretty high too, right? That's like a little bit worrying for like arrhythmias and like things like that. Yeah, I know. I guess COVID. I mean, that could cause fatigue, but I don't think it would be wise to just attribute everything he's been having, which could all be attributable to COVID. But since, as we kind of talked about, it's such a complex patient, we definitely have to rule other things out. I'd be worried about someone being uremic with that high of creatinine. Do we know what his baseline hemoglobin? His baseline hemoglobin is?
Yeah. Okay. Yeah. Some really great points there. Trish, really good point about his white cell count being low. If you're concerned about infection, it being low could be attributed to his immunosuppression. So we can't rule out infection just with low white count for this patient. And also picking up on the creatinine, the potassium, those could be signs of renal injury, how you get those changes. And also really good thoughts about the COVID positivity. It's important to consider it, but given this is a very complex patient, you don't want to hang your hat on that because there's some other really dangerous things that you want to make sure to rule out.
The other thing that I just was looking at is in the context of the ultrasounds. I'm not particularly familiar with the sensitivity and specificity of those or the best indications for them, but I'm assuming you could rule out a marked stenosis of renal arteries with the transplant ultrasound. So that's, I guess, pertinent negative here. And then we might see some signs of fibrosis or an acute renal failure potentially on the ultrasound, which maybe we're not seeing.
I think excellent interpretation. It's great at telling you if there's a vascular problem with the transplants. So no stenosis, no thrombosis. Then you use enzymes and creatinine as a surrogate to tell you if you should be worried about things like rejection. So I think it's pretty reassuring in this patient from a liver transplant perspective that the vessels are open, there's no blockages, and that the liver panel is within normal limits. Yeah. Same with the renal transplant. Vessels are looking okay, but maybe some kind of AKI and CKD happening.
And then also just wanted to make a few points about transplant patients. So when we think about complications these patients can have, we think about their immunosuppression, complications from either having too much immunosuppression or complications from too little immunosuppression. So if you have too much immunosuppression, one thing you're prone to are infections. So we can think about community-acquired infections, reactivation of infections like DZV or TB. They're at risk for hospital, nosocomial infections, things like MRSA, Pseudomonas. And then also you need to be on the watch for opportunistic infections, things like CMV, Epstein-Barr virus, pneumocystis, fungal infections, TB. So those are all infectious things you need to think about. And the other thing that can happen if you have too much immunosuppression with transplant patients is risk for malignancies. So this is driven because most of the time because of immunosuppression, but sometimes if you have concomitant viral infection, that can lead to malignancy. Essentially what's going on is if your immune system is suppressed, it doesn't have as much ability to recognize abnormal cells and eliminate them, so they can proliferate and predispose you to different cancers. So some of the most common ones are Kaposi sarcoma, skin cancers, lymphomas, specifically non-Hodgkin lymphomas, and also solid organ malignancies. So for liver transplant patients, they are at risk for developing hepatocellular carcinoma. Kidney transplant patients are at risk for developing renal cell carcinoma of their native kidney, not of the new transplant kidney. And also some patients are at risk for developing lung cancer if they've had like heart, lung, liver, or kidney transplant. And then on the other end of things, if there is not enough immunosuppression, you're at risk for rejection, like you had mentioned, Tina. So rejection actually is most likely to occur within 6 months from the transplant. It can happen later than that, but those instances are more likely to not following with like the treatment regimen they're on. So those can like present with sort of general symptoms, but also you can see like more specific symptoms to the organ. So like with the liver, abdominal pain, ascites, or kidneys, like oliguria. So at this point, we got some history. We like have pretty good differential going on, about infectious causes, thinking about rejection, possible malignancies. So what would you like to do next at this point?
I am a little bit worried about the patient's like electrolytes and hemoglobin. Like I would definitely, if we don't already have it, get like a Titan screen.
Yeah. Say, how about we go to examine the patient? What are like some things you'd want to look out for on the exam, physical exam?
Yeah, I think in terms of, I guess, going by systems or like head to toe, take a look at their eyes, or there any signs of jaundice on their skin. I would do like a neuro exam, look for signs of like asterixis, overall mental status could be affected by the, AKI on CKD. Listen to the heart. Are they tachycardic? Do they have any arrhythmias or like, irregular rates or rhythms? And in terms of like lungs, they've had for preventing shortness of breath. So are there any like adventitious sounds that would be suggestive of like a pneumonia or an effusion? And abdominal exam, look at the like scars from the transplant, see if you can palpate any masses, if they have any abdominal pain, maybe even like a rectal exam. Do they have any blood in the stool? Things like that.
Great. Yeah. All right. So let's go ahead and examine the patient. All right. So on exam for vitals, the patient is afebrile, heart rate in the 70 to 80s, blood pressure 110 to 130 over 70, respiratory rate 16, and satting 97%. He's well appearing, does not appear in any acute distress. For HE&T exam, pupils are equal and reactive to light, extraocular movements intact. There is tenderness to hard palpation of the left maxillary sinus. No proptosis, poor dentition, no skin changes, decreased sensation to the left nose and the skin over the sinus, no lymphadenopathy. For pulmonary exam, unlabored breathing, lungs are clear to auscultation, no wheezes, crackles, or rhonchi. Cardiac and abdominal exam are normal. Extremities are warm, dry, no lower extremity edema, palpable pulses. For MSK, he's moving all extremities, normal bulk and tone, no spinous process tenderness to palpation. For neuro exam, he is alert and oriented, and no focal deficits. So, how does this exam impact your thinking?
Yeah, this is kind of an interesting exam. So just looking at it from beginning to end, hemodynamically, this patient is pretty stable, static well. Most kind of abnormal thing that was pointed out is in the HE&T exam with this hard palpation of the left maxillary sinus, and then the decreased sensation in a very localized distribution, as well as poor dentition. And while we didn't get a lot of social history from this patient, again, he's a 40-year-old guy, so it strikes me as a little bit abnormal that he has poor dentition. The localized, almost dermatomal distribution that it seems to be describing with the left nose and skin makes me worried about zoster or some kind of other viral infection that can localize there. And then also given his profuse immunocompromise as well as transplant status, diabetes, thinking about mucor, aspergillus, any sorts of infections that can enter the body and have a preference for like nasopharyngeal infiltration. But the abdominal exam being unremarkable and cardiopulmonary exam also being unremarkable is reassuring. I don't know that I was very concerned about seeing signs of liver dysfunction on exam because his LFTs are within normal limits, but it's good to see on exam. Nothing like that.
And one thing that you guys mentioned during the previous aliquot was after seeing the hemoglobin of 7.2, and we didn't have a baseline for this patient. Now with these vitals and with this exam, is this a patient who you want to give blood to?
No, I think just get a type and screen ready just in case, but
Yeah.
not urgent.
Kaushik brings up a great point. Like with normal vitals, normal heart rate, normal blood pressure, probably a chronic process, not acute blood loss. Because if someone went from 14 to 9 suddenly, their hemodynamics are probably going to change. So this person's body is adapted to their degree of anemia.
One thing I was also thinking, which is like, it's actually pretty rare, but just worth considering in differential. And I also have recency bias because I saw a case today. But like with a palpation or painful like sinuses, you know, if you're immunocompromised, you're like susceptible to EBV, and there's like nasopharyngeal carcinoma, which actually can be like disguised as like a chronic sinusitis. And like we had an interesting case where like they just found the pathology of it and they thought it was just some like nasal mucosal like debris, but it actually turned out to be like a nasopharyngeal carcinoma.
Wow.
It's probably not that.
All right. So at this point, what other workup would you do at this point? Any like imaging that you want to get?
Well, just going back to the previous aliquot, given the abnormal electrolytes, I would get EKGs and monitor the lights closely. I'm thinking about the best sort of imaging of the sinuses, but definitely would consider some kind of imaging to further visualize what we're seeing. Potentially a CT versus an MRI, not less likely an X-ray, but something to visualize the soft tissues and see if you can see any changes or deformities.
I think it was like a CT maxillary sinus.
I defer to the
something.
radiologist.
Yeah, where I mean you can see the sinuses pretty clearly. So I probably would lean towards that before doing an MR.
Okay.
I think I would still get a chest X-ray in this person, given his progressive shortness of breath. Interesting, nothing on exam, but I think it's worth getting a chest X-ray. Let's see.
Are we talking about labs as well?
Yeah.
I would send a pretty broad infectious workup for this guy. So he's going to get a full viral workup with EBV, CMV, all the herpes viruses. I would probably send levels of all of his immunosuppressive medications that he's on, because maybe he's under or over titrated. I would send blood cultures. Let me think. Potentially fungal cultures too, just because of his profound state of immunosuppression. And then I don't know the value of swabbing this patient in the nasopharyngeal area, because that could give you maybe different information than from the blood. So
Wow. Yeah. Really, really good considerations there. So we did get CT of the sinuses. So great thinking, Tina. And here is the image, and here's the read. So there is one, complete opacification of the left maxillary sinus, a focus of mineralization and subtle hyperattenuation in the left maxillary sinus, abnormal soft tissue with involvement of the left infraorbital nerve and canal. There is bony thinning/erosion of the left orbital floor. 2, complete opacification of the sphenoid sinus and overall moderate sinus mucosal disease in the remaining paranasal sinuses. And 3, fluid levels and/or aerated secretions in the frontal, ethmoid, right maxillary, and sphenoid sinuses would be consistent with acute sinusitis. All right. So what are we worried about here? Like, is this an emergency?
I feel like I'm like more worried about the mucormycosis because it can cause like necrosis, and I would consider that urgent, if not emergent.
yeah, I agree. I think in this patient, you don't think about this read as a normal run-of-the-mill sinusitis. You would further work it up, and especially given his like new symptoms.
Yeah. So is there anyone that you would call in the hospital at this point?
ENT.
ENT? All right. Yeah. So let's give them a ring. So they come by and they do a flexible rhinoscopy. So they have findings of no concerning lesions, areas of necrosis, or purulence noted. They take him to the OR for sinusectomy and debridement, and they send off samples for path and cultures. Frozen sections are positive for fungal elements, and the patient is empirically started on amphotericin B. So, you mentioned something before, but what organism are we most worried about here that we're covering with amphotericin?
So it's like mucormycosis, but I know aren't there like multiple bugs like Rhizopus
Yeah.
and mucor are like two different
Red mold.
genus.
Yes.
That can cause it. Yeah, and just I think Trish mentioned earlier, thinking of like patients, it's like common if you're like immunocompromised and also patients with diabetes, particularly poorly controlled diabetes. And so that's actually something that would be good to know from the history is like how well controlled his diabetes has been. And maybe if his CKD is from the diabetes, maybe it's not controlled super well.
What do you think about amphotericin B? Broad or narrow?
It's quite broad.
Very broad. That's like the fungus. If you just want to get the fungus,
Yep.
I would give them
It's all that
amphotericin B.
covers Mucor too. So
Yeah.
Yeah, and one reason we're like so concerned about Mucor is it can be like very deadly. Like mortality is I think around 50% or so. So yeah, all right. So we have him on some broad fungal coverage with amphotericin. We'll see what happens next. So patient is still having shortness of breath. So we get CT of the chest. So these are the findings here that show one, a new patchy solid nodular densities, most prominent in the left lower lobe, and also a right pleural effusion. So the pulmonary team is consulted for evaluation of bronchoscopy to help elucidate the cause of the lung lesions. They agree. Bronch studies are now pending, and ID adds on 16S and 18S PCR to the pathology. So I guess starting with like the imaging here, this CT of the chest, what are you thinking with these findings?
I mean, I think you think of like Hickham's dictum versus Occam's razor in this case, and I'm thinking, is this an extension of his disease that we already know about with the fungal mucor that now has spread to his lungs and he has some lesions there, versus does he have a new like exudative pleural effusion? Does he have new disease that's localized to his thoracic cavity? I'm still thinking about something infectious that's causing a new fluid collection in his lungs.
Yeah, because originally I was worried about, maybe it was like a COVID pneumonia, 'cause since we know that he's COVID positive. But this really isn't the typical like CT presentation for COVID pneumonia. It's usually more like ground glass opacities in like the peripheral lungs. These like patchy solid nodular densities. I mean, that could be in like, I'm more worried about like some sort of other fungal or bacterial infection versus malignancy in that case. So, and I in my head, I don't really have that many like connections between mucormycosis and like a thoracic infection. So I'm like a little worried that something else could be going on too.
Are there any specific other things you think it might be?
I mean, profound state of immunosuppression, I'd want to rule out any types of atypical mycobacterial infections, which could have some nodular lesions. I think one of the most common presentations for patients with TB is new shortness of breath and pleural effusion. So we definitely want to rule something like that out.
I think the 16S, 18S PCR is interesting. I actually didn't know that we had that here, at least 18S. And I don't exactly know how it works, but I'm assuming that it just like widens the panel of organisms that we can.
Yeah, that's a great
Test for.
question. So actually great segue into like little teaching point about the 16S and 18S ribosomal RNA. So these are the rRNA, like a piece of the ribosomal RNA. And so prokaryotes like bacteria, they have like different subunits, including the 5S, 16S, and 23S gene. And then eukaryotes have 4 different subunits, 5S, 5.8S, 18S, and 28S. So 16S is like specific for the prokaryotes, and then the 18S is going to be specific for eukaryotes, so like fungal organisms. Essentially what is being done is it's like done with PCR. They amplify that section of the gene, and then they sequence it, and they can compare the sequence to like a bunch of known organism sequences, and that's how they identify which organism it is. Some of the advantages of this sort of testing is it allows you to do broad detection because you're like amplifying with PCR. You don't have to necessarily know specifically beforehand what it is because you're comparing to the database. And also this is independent of any need for cultures. So if there's organisms, that take a long time to culture or it's just very difficult for whatever reason, you can sort of work around that with the 16S and 18S rRNA. So I think in terms of how long it takes to resolve, it kind of varies on institution. I think can take anywhere from a few days up to a few weeks, depending on resources, but can be a helpful tool in the infectious workup.
I think one thing about 18S though is like in eukaryotes, like the 18S is it's like variable in length, like in all bacteria, like 16S is pretty like uniformly across. And so you kind of have like a problem when you do PCR with like an 18S because you're like, if you're doing like traditional PCR, you're only getting like the ends of it. And so I actually haven't seen 18S actually be used in terms of like clinical use. But I just thought it was really interesting.
All right, so we have some more information now for our patient. So he undergoes thoracentesis that was exudative, but nothing grows on cultures. The bronchoscopy with BAL and biopsy demonstrate fungal hyphae, but otherwise are non-diagnostic. And pathology from ENT shows an invasive fungal infection. So what invasive fungal pathogen should we consider at this point? We've mentioned a couple of them.
Aside from Aspergillus and Mucor, which we both talked about.
Yeah. I mean, fungal hyphae, that's usually not like, I mean, blastomyces, that's usually more like yeast shape. So I forget. Do you know?
Yeah, I
It's
think
like Canada.
Canada,
That's,
I don't,
I think
they
it
have
depends
both.
on the temperature.
Dimorphic.
Like,
Yeah. Think about like histoblasto and less likely
they describe
Coxypara, Coxy. Yeah,
They
they
describe the angle and branching.
You mentioned Rhizopus earlier too.
Yeah, or like Cryptococcus. Maybe. But that's more
yeah, meningitis.
That's most likely.
Yeah.
I mean, realistically, we would do a broad workup for all of these fungi because we don't know, but
Right, yeah. Yeah, Mucor, Aspergillus, Rhizopus, Cunningham, all these are like possibilities. So, our testing comes back, the 16S and 18S RNA. But unfortunately, it comes back negative. But we have some other testing, the Carius testing. Essentially, this is like a liquid biopsy for infectious disease that provides genomic insights by detecting microbial cell-free DNA that's circulating in the bloodstream. And that comes back positive for Aspergillus fumigatus. Yes. So, what are your thoughts now at this point, taking all into account that we've learned so far?
this Carius testing was sent from the Thora fluid. No,
I think it's a blood.
this is the blood.
Yeah,
test.
serum.
Okay, serum.
I just learned about it today, actually. It's my bad.
This is Hickham's dictum or Occam's razor.
I think. I'm assuming it's just like two different.
Yeah, I would think of it as victim's dictum. Two different infectious pictures for this patient. Think about like voriconazole to add on for treatment while we're here.
Yeah. All right. Great work. So we have a resolution of the case here with final diagnosis of acute invasive fungal sinusitis and pulmonary aspergillosis. So, got it. And the resolution, yeah, he undergoes multiple debridements, was transitioned to voriconazole. Nice work, Trish. For a prolonged course, his symptoms continue to improve, and he is now doing well. So, yeah, fantastic
job.
work going through there.
You guys were spot on early. Your reasoning, you were focusing on really important things, and then took the information as it came in and worked towards these more atypical fungal infections. You were totally right to think about Mucor first, because Mucor is very fatal, even with treatment with amphotericin. Still really poor outcomes. They often require massive debridements, and still then the outcomes are poor. So that's a can't miss diagnosis. And so I think you were right to think about that. And fortunately for this patient, they didn't have that.
All right, so to wrap up here, I just want to talk a little bit about fungal infections for transplant patients. So focusing on kidney and liver, because that's what's applicable to this patient. Most common fungal infections you have are for kidney, would be Candida, followed by Cryptococcus, followed by Aspergillus. And the liver, most likely Candida, followed by Aspergillus and Cryptococcus. So Candida, Aspergillus, you are thinking about those. And also another thing that can help is the time course of where is the patient relative to their transplant. So our patient was 6 months out from the transplant. Sort of in that initial 6 months, that's when bronchial Aspergillus is most likely to present. Candida infection more likely in the 3 to 6 month range. And then other invasive forms of Aspergillus more 6 to 12 months. For endemic fungi, like you mentioned, histo and blasto, those are most commonly more of a late manifestation and occurring over a year after initial transplant. But there is some data that suggests it might have a bimodal distribution and also occur in that first 6 month period. So another thing I want to talk about, in terms of the imaging we got, we saw the nodules, and Tina, you mentioned how like, it didn't seem consistent with like a COVID pneumonia. And so the pattern that we saw there, the nodules are actually the most common radiographic finding of pulmonary fungal infections, and aspergillus in particular is the most common cause of nodular pneumonia. And last point relating to like your interest in derm, Trish, for the transplant patients, because they're immune suppressed and they have like less inflammatory response, like typical like skin lesions that you normally see in fungal infection could like present very differently in these transplant patients. So even if they have some skin lesion that might look like a simple cellulitis, you should always like be thinking about like abnormal or like fungal infections. So you really want to get like skin biopsies in those cases. This patient didn't have any skin findings, but that could also be a result of like his immunosuppression in the transplant. So fantastic work, guys.
Yeah, you guys nailed it. Any final thoughts?
No,
That's
it's yeah, lots of fun and nice to think about. The time course with fungi, I think, can be a little bit of a black box and a kind of cause for exclusion after you've worked up a lot of other things. We think about, this might be fungal, but it's important to have it on your differential and the transplant patients. So
Yeah, I think like it's just a good exercise to think of like immunocompromised patients and then all the different like types of infections and things that they're susceptible to. I think it's like a way to like, I think you can have a full differential in terms of including bacteria, viruses, and fungi, and like that's just a good way to organize it and basically think they're pretty much susceptible to everything at that point.
yeah. Too bad there were no skin findings.
Thanks again for listening. Person, time, and place. See you next time.